Hi guys, so now we're going to be going over three leads and hemodynamics and then some of the other stuff involved with the three leads in terms of knowing like your lead correspondence to the heart arteries and where you're going to see all that stuff. So I'm going to go over this. I feel like it's really helpful to go over this stuff because for me, the way that I learn is by breaking everything down. I have to understand why behind everything, unfortunately, so that I can really be like, okay, that makes sense why that's happening. So yeah, I feel like whenever she explained the three leaded stuff, I was so lost and confused. I remember going to B80 and being like, I have no idea what's happening now. But I think it's because again, you don't really have time to be breaking it down between classes, clinic, all that stuff, and you have to wait kind of before the exam and before you're really studying. So I kind of made this as a little bit of more explanation because I feel like again I didn't really understand like what really is an electrode, what's a lead, what are these other definitions. So I feel like this hopefully can help break some stuff down to make it a lot clearer. Um, because I feel like after I broke it down, then it was like with the things that she was saying, I was like, oh, okay. See, that was just something that I had to do on my part in terms of understanding this information. So for mnemonics, I think we all know the mnemonics like clouds over grass. So you know that the white lead is going to be over the green one. You know the black lead is going to be over the red one, smoke over fire. And then you know that the I heart chocolate is basically the V1 that goes into the center of your chest. That's the brown one, right? So in terms of the other thing that I put on here was the white on the right because I feel like some people also forget um, where which color goes where. So you know the black goes on top of the red, but is it on the left side or on the right side, right? So white on the right is kind of another acronym to add or mnemonic to add for that as well. And for V1, so obviously we know that V1 it's in the center of the chest. It's that brown. I heart chocolate right there. So when we're talking about V1 throughout this little lecture or review, basically I think the biggest thing is to know that it's the best for seeing ventricular ectopy. So when we're talking about the three lead and other things in general, if you see a question where it's like, okay, like what's the best for seeing ventricular ectopies, you know, it's V1. So it's sitting at the fourth intercostal space, at least for this brown lead wire, but really it just have to be in an exact spot. But the other leads can kind of be more in a general area, just because this one is again the best for seeing ventricular ectopies, and we'll get into some of the other definitions here. So for ground electrodes, what is a ground electrode? Well, that is your reference point to basically stabilize all of these readings right here. So it reduces the noise interference with external sources, but really, so when it's saying ground electrode, it's basically that electrode that's grounding everybody, right? All of the different leads are going to be doing different things. There's still obviously other external sources outside of our in our environment, so it can kind of read with or interfere with the readings that the EKG is trying to pick up. But keep in mind, I kind of think about it like you know how like they tell you to turn off your phone or electronical devices. They put it on airplane mode when you're on a plane, right? It's kind of like the same thing, but you have that ground electrode that's helping to stabilize all of those things. So in a five lead EKG, that right leg one, which is your again your green, right? And you know that it's on the right side because white on right, and then you know that there's the clouds over grass, so you have that. So your right leg, so your green, the in a 5 lead EKG is your ground. So that's stabilizing the rest of these electrodes to be able to get a proper reading. So yeah, and basically it doesn't necessarily measure heart activity, it just helps to ground the rest of them, and that's the whole point. So what are leads? So that's a good question because again, like what are they? A lead is a representation of the heart's electrical activity, right? So it basically is recording, getting your data to see between every single electrode, what is the heart activity between that, right? And each lead measures the voltage between those 2 points of the body. So when we're talking about leads, there's different types of leads, and I think it's actually really important to know these things because then again, you can break it down a little bit further. So types of leads. You have bipolar leads. So obviously with the when it says bipolar, you're talking about two. So basically these leads measure the voltage between two electrodes. So when we're talking about lead one, you know that you're gonna have to have two electrodes for that. When we're talking about lead two, you're gonna have two electrodes from that. When you're talking about lead three, now you got another two electrodes for that. So when we're breaking it down within a five lead, let's talk about lead one. So it compares the voltage between the left arm, which is positive, and the right arm, which is negative. So right here, you know that these two, oops, is your lead one. And notice how it's going one from a positive and negative. You always have to have a negative and positive correlation, right? Because that's how the electrical activity works. Um, Within the system, you go negative to positive. It's kind of like with batteries too. So you have that. So that's where your lead one is coming from. So I think when we're talking about the three lead, I understand why it gets confusing. All you have to remember is if you remember that your right top or your left top one, which is the LA, if you remember that that is your positive electrode in lead one, and then when we're talking about lead three, it becomes negative. But really, I mean, the only other thing, and we'll get into it, your bottom left leg one is positive. And so when we look at the three lead one, even though we switch colors, the bottom one is still positive. And then the top one is going to be negative, and I'll talk about it in a second, but that is a lead right there. So let's get back into it because I feel like it'll make more sense whenever I keep talking about it. So lead one, that compares the voltage between the left arm, that one's a positive one, and then basically it goes to the right arm, that's a negative one. Those are two electrodes right there. They're comparing the voltage between it. Now you have lead one. Okay, when we're talking about lead two, it compares the left leg, which is a positive, right? And then the right arm, and that's a negative. So obviously a positive, negative. Now you got another lead, that's lead two. So then we're talking about lead three, that compares the left leg, which is still positive. Let me do a different color. Okay. And then now it's also connecting to the left arm, which is also going to be a negative one. So you can see that the left arm has both a positive and negative charge to it. So it changes in response to what lead it's in. So if I'm looking at lead one, I know that it's in a five lead, right? I'm looking at the right arm, the left arm, and then I'm looking at that the fact that the white one's on the right hand side because of the mnemonic, and the left one is going to be black. But basically, negative, positive. But then, if I'm looking at lead three, I know that I'm going to be looking at the left leg and then the left arm, right? And that's going to be your lead three. And then I know that the bottom one, the left leg, is going to be a positive charge. So then I'm like, okay, now my left arm should be the negative one. So I feel like if you, at least for the five lead, if you know that your right arm is negative, your left leg is positive, really your left arm is going to be the one that switches between each of the leads that you're going to be looking at, right? Does that make sense in terms of the charges? It does. The left arm does change from, it can be positive, negative in correspondence to if we're looking at the right arm or the left leg. Because again, you need to have a negative and a positive for each of those things. And then in terms of just the lead two, because the left leg is only positive, because the right arm is the one that's only negative, obviously you have another lead that's going between them two as well. Um, in terms of unipolar leads, so this is talking about one, right? Because so universal, you're talking about there's only one. So these leads measure the voltage at one electrode relative to the center point. So what does that sound a lot like? Well, that sounds a lot like a ground, right? Because the ground is the one that's kind of just stabilizing these readings. Um, and it just has a central point. So when we're talking about this, it's just going to be usually a ground. And so for an example, obviously in this one, you have your right leg, and that's kind of more of the ground one right there. So it's not having an actual lead. It's not monitoring actual activity. It's more of just measuring voltage. It's kind of just helping as a relative central point. It helps out more with that. In terms of precordial leads, that's V1 to V6. So when we're talking about like memorizing some of these leads down here, those are basically your precordial leads. So those are even more leads that you have, and these are technically under unipolar leads as well, because they're each individually kind of measuring activity by itself. But again, it just provides additional views. So really, like these main ones, when we're talking about the bipolar leads, are the ones that you're really like, okay, there's two of them. It's measuring that voltage between two of them. Unipolar, it's kind of just helping with the activity, measuring the activity for there, but it doesn't directly like relate to two different ones. It doesn't measure the voltage between two different electrodes. It's just kind of more there. And precordial is basically just talking about more additional views that we can see for V1, V6. So when we're talking about this little chart right here, know that V1 to V6, you only have to know um, kind of where they're lying, but I feel like if you understand, they're just additional views, right? So when we're looking at 1, 2, and 3, that's more of looking at those leads right there. And then AVF, AVL, AVR, those are other different ones that you can see. But V1 to V6, additional views for that. So I feel like if you understand that, that's why it works. So now again, talking about the 5-lead electrical direction, when we're talking about the right arm, again, that's acting as your negative electrode for lead 1 and for lead 2, right? Because it's going here from lead 1. Oops. It's going here for lead 1, and it's also here for lead 2. In terms of the left arm, it serves as a positive electrode for lead 1, and then it serves as a negative electrode, right, for lead 3, because again, the left leg is positive at the bottom. And obviously the left leg acts as a positive electrode for both the lead 2 and the lead 3, right? So both the lead 2, sorry for all the highlights, and then the lead 3 as well, right? And then the right leg serves as a grounding electrode. So we know that that's there right here to help stabilize the readings. And then the V1 is a precordial lead as well that provides a view of the heart's electrical activity, also kind of just helping out, but it also helps with assessing some of the right ventricle and the septum, some ventricular ectopies as well is another thing that we're kind of looking at for. So we'll come back to the coronary arteries and monitoring leads and all that stuff because I want to explain the 3-lead and get into that. So I guess why this is so confusing is because it changes like some of the stuff. But again, let's break it down. So basically, in this, we're going to remove the V1 and we're going to move the right leg, the ground electrode. And the reason why is because, again, those were some of the extra ones that we kind of just used to help stabilize a reading. However, you do still need a ground electrode in this, so we need to get it replaced. So I would just think about it like, okay, if I'm going for a 5 to a 3, I don't necessarily need, I'm going to have a different ground electrode, so I'm going to take that right leg out. I don't need a V1 right now, so I'm going to take that one out, right? So this basically only leaves your red, your black, and your white. So in terms of how it's going to switch, I'm going down to the second bullet point. So basically when we're switching, the 3 leads now switch, or the electrodes switch counterclockwise in terms of color, right? And only in terms of color is what I'm talking about. Because, okay, so you know that the white was on the right side of your body, right? Well, now it's now on the left, right? In terms of the black one that was on the left, well, now it's just going down to where the left leg was out in the red, and it's going down. And then in terms of the red, you know that it was at the left leg at the bottom, so it's going to be taking the white spot because again, the brown one, it's not gonna, that's a V1, right? So it's just wanting to go all the way to the top, and now it's over there. So you're kind of switching the colors clockwise, if that makes sense. So just know that in terms of how we're switching it, we're taking off the V1, which is the brown one. We're taking off the green one because that was our ground. And now you switch the colors clockwise. So now you know the red was on the bottom, so it's gonna be all the way at the top. You know the white one was over here on the right. Now it's gonna be on the left, and then you know that the black one was all the way on the left. Now it's gonna be all the way at the bottom. However, so this is where it can get confusing. However, you still need a ground electrode, right? So your red one is going to act as your ground electrode, and then we'll get into some of the other stuff, but let's get into kind of how this all works out in terms of monitoring. So what is the modifying lead in a modifying chest lead? So when we say MCL, just know that we're saying that we're enhancing monitoring specific situations. This whole thing is basically MCL1, right? But really, when we're saying like what's the modifying lead, it should be lead 1. So over here, you have the ability to see lead 1, lead 2, lead 3. For this one right here in the 3 lead, you're only really going to be seeing and setting the monitor to lead 1, right? So the computer then will assign the charges. I forgot to type that in there for the electrodes. So in terms of you switching the colors clockwise, you know that your white one is going to be negative because up here, if you look at the left arm, um, and the left leg, that one is your lead 3, but you know that the left arm was the negative, right? And then you know the left leg was the positive. So the bottom one you know was the positive one. So if you're looking over here, when you're looking at lead 1, yeah, we're talking about the white and the black, right? You know the bottom one's still positive, the up one is still negative um on the white side, so that is your lead one. So basically you're setting the monitor to lead one. So white is going to be negative, black is going to be positive, and red is now ground. So really all you have to do is just understanding you're switching the colors of the electrodes. So it's just going clockwise, but in terms of the charges, it still should be remaining the same. And technically, I get the question is like, okay, well, on the left hand side, on the 5 lead, it was positive for lead one on the right side, and then so like right arm, left arm, that one was negative to positive, and then when you're looking at the left leg and left arm, now the left arm is negative, right? But over here, it's just going to be negative and it's just gonna be positive. Like, it's just gonna be negative, and the black one's just gonna be positive. And the reason why is because the only thing that you're looking at here is lead one. Right here, if you're looking at the white going to the red one, well, your red one is your ground now because you need to have a ground that stabilizes every single, all of the electrodes together, stabilizes your reading as a whole, right? So of course, it's not going to the white can't go to the red because it's just a ground lead. So there was no charge or voltage going between that. That wouldn't work. So you only have one lead that you're reading here. So again, it's not going to be um, changing its charge, right? It's going to stay negative because really the only lead you're looking at is the lead one, which is going to the bottom part, which is the black one. I hope that kind of makes sense. So basically, your red is now on your right arm, your white is now on your left arm, and the black is actually going to go in the V1 position because, again, keep in mind, the V1 position is the best for seeing what? It's the best for seeing ventricular ectopies. Additionally, your brown one in the 5 lead, that was your V1, right? But you're basically just wanting to, I would think about like shift it up almost, because again, you're going clockwise for the colors. So you just have to also remember the black one is just going to be in the V1 position where it was for the brown one, which is going to be like the center of the chest. So again, when you were assigning the monitor to lead one, it's basically reading the white, which is now on your left arm, which is negative, and then your black, and that's now in the V1 position, and it's assigning that whole two voltages, so it's a bipolar lead to lead one. So I hope that kind of makes sense, but really, again, to kind of summarize it, looking at the 5 lead, you know that the white is on the right, you know that the black is on the left, so when you're looking at that, all you're going to do is, in terms of the colors, switch them clockwise. You're taking off the ground for the 5 lead, so that was the green one. You're taking off the brown one because that was your V1. The black is going to take its spot. And then all you have to remember too, the charges are remaining the same. We don't have the ability to have um, the one on the left go from a positive and negative because the red one is just a ground. So the only thing that you have left is the white, the black at the bottom. That's going to be lead one because you know you want to set the monitor to lead one. You know that the black is still positive because um it was up here, right? But then when you go down here, it's like, okay, again, the white can't read with the red. There's no other lead. So it's going to just be negative, positive charges for those two. So I hope that makes sense. But to clear up some more stuff about, V1. So basically, V1 best for seeing ventricular ectopies. 3 lead system. When you position the black lead in the V1 position, it basically again allows that focus to be on the right ventricle, in the septum, which is again good for detecting more ectopies. And then um, a modifying chest lead configuration enhances monitoring in a 3 lead setup. But again, V1 best for seeing ventricular ectopy for that. So if you're still having some difficulties, I would recommend to maybe watch some videos about it. I feel like there's not really much that I think it over explain some stuff, so that's why I tried not to over explain some of these things. It's just kind of like what you have to know. I use ChatGPT to explain everything to me when I'm confused in terms of some of this stuff. Just because I feel like if you have a conversation with ChatGPT about being like, "Hey, I'm still not really understanding this," and you can even talk to it too and be like, "Hey, so if I'm getting this right, a 3 lead, I'm going to be switching it clockwise, doing these things." So the thing though is sometimes it can be a little bit messy or almost like wrong, but you'll catch it and you'll be like, "Oh wait, but this is what it says, so this is what goes." So and then it's like, "Oh yeah, you're right," but that just means that I know what I'm talking about. So I would just recommend to do that because that's always what I do for any of this information, and to just look up some questions I might have. In terms of skin preparation and electrodes, I feel like you guys already know that. It's the same exact thing as before. Dry the skin. You can clean it with soap and water, but make sure you get rid of it. Make sure it's dry. You clip some hair. You got to shave it. Do what you got to do. CPR. That's the best plan to prevent from happening in the. So the best plan is to prevent CPR from happening in the first place, right? We don't want the patient to get to that. So if we can understand some of the core issues and the origin of how they got, so kind of like the H's and T's, then, that's kind of what we wanna do. CPR would obviously be kind of the last thing. If they really needed it, then we'll do it. Rapid response team, you guys know what that is. It's basically to prevent a cardiac or respiratory arrest from ever occurring. So in the hospital, you know that your patient, maybe their vital signs are going crazy, you already gave some meds, already did all of these things, they're having really bad chest pain, you gave nitroglycerin 3 times every 5 minutes, their heart is now kind of going into different rhythms. It's going into a third. Maybe it's going into, you're seeing some atrial fibs. You could see a lot of different things. But basically, at this point, they're getting short of breath, they're getting diaphoretic, their blood pressure might be dropping or increasing or whatever. So then you can call a rapid and be like, I'm kind of sensing that something bad's going to happen. So let's get other people in here to see what's going on. So yeah, and then in terms of responsibilities in the code, I feel like you guys kind of know it. You have different things, and honestly, she probably won't even ask you. So now, oh, I forgot to go over the leads and stuff like that. So we'll get to that at the end because I was gonna say we only had to have a couple more things to do. So I don't even think you have to really know some of the geriatric considerations. I feel like maybe just read through it, but um, again, it's always the same things, right? Complications. You're gonna have rib fractures because their bones are a little more fragile. So when you're obviously compressing somebody's chest, very much happen. You can end up actually having a pneumothorax, hemothorax. But again, it's kind of like risk versus benefit. Yeah, sure, I can crack their rib, but at the same time, if I don't perform CPR, they're gonna die because we need to get that heart pumping, and we need to be able to have it contract so we can get blood to the rest of the body, get everything oxygenated, perfused, and so on. So, obviously, in terms of like hepatic renal functions, you kind of know that already, right? They can have a higher concentration and more adverse drug reactions because of the dysfunction that's happening as you age. And then so on and so forth. You can read it. But basically, BLS, ACLS, when you guys graduate, depending what floor you go to, you all have to really learn how to become an ACLS provider. Maybe if you're not working with kids, you'll do PALS and then NICU. I don't even think you need ACLS. But um, in terms of this information, BLS, what you guys do now, compressions, giving those breaths, responsiveness. ACLS does include that, but now you're just having more other things to that. You can also give medications. You can also, well, you can't intubate, but you get, the patient, you prepare them to intubate with the provider. You look at end tidal CO2. And you look more at what are the causes, which again, we talked about the H's and T's. In ACLS, they will ask you, like, what are the H's and T's because you're looking at what is the cause of this issue. And then again, you still do CPR, you still do defibrillation, but let's say you're also adding, like, you're putting them on their pads, you're reading their rhythm, just like how you would with an AED. It's a little bit different, but you would then either defib them if they are like impulses VTAC. There's so many other things that you can do. Kind of following the SCREAM acronym is basically what we're talking about sometimes for some of these rhythms. So ACLS is just more advanced for that. But really, for medication administration, what she wants you guys to know is the IV meds that you can be giving or in the endotracheal tube. And that medication acronym is LEAN. So just memorize that because she will ask you about that for sure. I don't doubt that she won't. I actually don't know if she did for this exam now that I'm thinking about it, but I know she did at least for the final. So, but you still should know this, right? Because this is something that she highlights on. So again, lidocaine, epinephrine, atropine, naloxone makes sense. Why we have these medications there. So yeah, just make sure you memorize that and kind of get that in your head because also it will help you to understand that, in the future as well. For therapeutic hypothermia, targeted temperature management, basically after we get ROSC, which is return of spontaneous circulation, right? So let's say I'm doing CPR on somebody who's in asystole. Oh, what don't you know? We got a pulse back, right? We got a rhythm, we got a pulse, they're breathing somewhat. So then you'll tell the provider, should we start like targeted temperature management, right? So it's basically after having a cardiac arrest, we're going to want to limit their neurological impairment by allowing them to, be within a certain temperature range. Because again, we're talking about the metabolic rate. Remember when we talked about the oxyhemoglobin curve, we're talking about metabolic rates, and basically, if we're on the right, left hand side, I'm talking about kind of yeah, how our body's doing in terms of its metabolism and overworking. And obviously, if you're having a higher temperature, you're going to need more oxygen. So that's basically what we're talking about. So this is what targeted temperature management is. We want the body in homeostasis. Really, what it is, it's we want to cool them for 12 to 24 hours. You can do it internally, externally, and you rewarm them slowly. And for ACLS, you need to be able to know this as well. So at the end of it, like after we did the ACLS training, it was like, oh yeah, by the way, they got ROSC. Okay, great. So what are you gonna do? What are you gonna do? Okay, well you can get them to like cath lab, or you can get them to TTM. Should we prepare for this? Do all these other things? Like, so it does come in handy to know this, right? And then always do what the patient wants. A slow code is never okay. When has it ever been cool to do a slow code? If a patient, I don't care if a patient is 90 years old. Um, and still wants full slow if she wants full CPR, the whole shebang, I'm going to be giving it my all. Even if we don't necessarily agree, because girl, you're 90, but at the end of the day, it is what the patient wants. We need to. Some people, and I'm sure there's cases out there, they make their own decisions, and they're like, okay, no, this person probably they're not going to have a good life after this, so we're not going to try as hard on CPR, not doing the compression rate, the depth, everything, which isn't cool. A story that I recently learned about was during Hurricane Katrina. I'm sure some of you guys heard about it, but basically, there was a couple of nurses who decided to make a decision for patients because, again, because of the fact that so hospitals obviously have generators, so that's what you see. Like the red outlets can be for like the backup ones, um, in case like our electricity goes out, anything like that. But uh, these nurses in Katrina obviously they didn't end up having electricity, but for all of, like, the patients in, like, critical care, things like that, they made the decision to euthanize them, um, and I kind of am, like, thinking about it, I'm like, "That wasn't your decision. They should have still provided care as much as they could have, and then what happens, happens. It's out of your control at that point." But even if, no, they decided to make the decision to euthanize them, and I think some of them lost their license. I don't know if they got arrested or whatever, but, yeah, I recently learned about that, and I was like, "Yeah, that's not our decision to make." And I feel like in that situation, um their poor families, their themselves, like, it's again remembering why we have it in our report, what kind of code they are. Are they a DNR? Are they a full code? Like, because again, that's just that to me is crazy, and it's surprising that a lot of nurses were okay with that. So don't be like that, please, because we're not here to make other people's decisions. We have our own opinions. Yeah, sure, maybe I would have been okay if I was one of the patients, if I was already not having a good outcome, sure. But again, that's not our decision to make. That's what I want for myself. And so, yeah, keep that in mind. But you should look it up too to read more about it because I was like, that's crazy. But anyways, getting back to the point. Medications for these. Um, what I would do for these ones, I didn't review them. I just read through it. I did highlight some of the stuff she highlighted in our class, but again, she didn't ask us anything about the meds. For some of these, you kind of should know a little bit about them. So obviously, like amiodarone, you can give it for um, arrhythmias, um, adenosine that helps to basically um, decrease some of your heart rate and dysrhythmias as well. So I would kind of say, I don't think you have to know that much about it, honestly. Anticholinergic, yeah. Calcium channel blocker. Um, epinephrine is important always. But yeah, I mean, I just went through some of this stuff because she told us to know it. She didn't ask us anything about it, so that's why I was like, "Ooh." Becaronium, we talked about it a little bit last time, and well, we didn't talk about becaronium, but we talked about the other one, which is sucks. This is the other non-depolarizing one, so it doesn't have that contraction. It just induces paralysis automatically. Cannot be used if patient is mechanically ventilated. You guys know that's the same thing with sucks, but yeah, I mean, I would just read through it, but honestly, I don't know. I don't think she's going to ask you about it again. Everything's fair game. And I do always have to like input in here, hey, just because she says it to me doesn't mean that's the same case for you. So what she said goes, kind of follow what she says with that. But I would definitely read it at least. But don't feel like you have to memorize this or anything like that. Because again, I don't think she focused on it that much. It was more of the SCREAM acronym, the lean, all that stuff. So um let me see here. Okay. So let me pause it really quickly and then we'll get started. Okay. Sorry. It's because since I'm recording, I had to take a little bit of a break because one of my friends was like, "Hey, you want Chick-fil-A?" And I was like, "Yep, I do." But anyways, so now getting into hemodynamic monitoring. So when we're talking about this, basically don't overcomplicate the terms because I feel like once you kind of when I'm talking about it, I hope it kind of lets you realize, oh, okay, that it wasn't that bad. Because I feel like when they're talking about it in class, I genuinely was like, I have no idea what you're talking about right now. All of the words are just mixing in, especially when it comes to like vents and stuff. But don't overthink it. Just try to listen to the name, try to break it down. Don't overcomplicate it. Go with what your first kind of thought is, and you're not wrong. So let's talk about some of the stuff and break it down a little bit more, right? So when we're talking about cardiac monitoring and hemodynamic monitoring, so resistance, how much of the blood vessels oppose the flow of blood? That makes sense, right? Like we're resistance to something. And when we're talking about having like resistance, I kind of think about it like when football players are like pushing the really heavy I don't even know what it is, but it's like basically to mimic another player and they have to push it. Like how much resistance, how much force do they have to use to oppose all of this pressure that they're having to use to push that? Kind of like when you're lifting weights in the gym, things like that. How much do you have to use? So in terms of resistance, how much do the blood vessels have to oppose the flow of blood? And obviously that's affected by the vessel length. So the longer the vessel, the more resistance that you can have, and that makes sense, right? Viscosity, thickness, the more thickness, the more increased resistance you're going to have. I feel like that one also makes sense. And then the diameter of the vessel, same thing. If you're having a smaller diameter, you have more resistance, right? And then if you're a compliance, which is your stretch, so know that your compliance is how much of that stretchy factor that we have, just like how our heart has that. Um, Decreased stretch, more resistance, right? So everything makes sense. If you're gonna be having a longer vessel, you're gonna have more. You're gonna have more thickness. Obviously, you're gonna have more, smaller diameter, more, decreased stretch, more. So just know that resistance is kind of what we're talking about in terms of um, when we talk about like afterload, contractility, all of those things. What is the heart having to do to oppose this flow of blood? So cardiac output and heart rate stroke volume. So obviously you know the equation cardiac output equals heart rate times stroke volume. So what are those things? Well, cardiac output, basically what is the total amount of blood the heart is pumping per minute. So this is what the blood ejected from the left ventricle is doing with each heartbeat, right? So again, knowing the anatomy of this, and that is a recommendation that I have for you guys learning some of the terms, like when we talk about right arterial pressure, all of those different things. You have to remember what we're talking about anatomy at the end of the day because you have to know that it goes from your right ventricle, then it goes to your valves, and it goes through your you know, you have to remember all of these different things because if you don't know that, then it's hard to understand. Okay, if it goes from the left atrium to the left ventricle, and then it's going to end up going to the rest of the body, right? So you have to understand those things so that it kind of just makes it a little bit clearer when we're talking about the different types of pressures. So again, when talking about cardiac output, this is the total amount of blood, right? The total. So it literally says cardiac output. So the entire output of what's happening. So normal is going to be 4 to 8 liters per minute. Okay. In terms of heart rate, we already know what that is. That's going to be 60 to 100 beats per minute. So you know cardiac output equals the heart rate, right? Because we're wanting to see what the heart rate it is, right? Um, because how much blood is being ejected with each heart rate. And then the stroke volume is the amount of blood, right? Ejected from the left side of the heart, right? Anatomy, going back to it. It includes preload, right? So this is where it can kind of get confusing, but just know, you know, cardiac output equals heart rate times stroke volume. So how much the blood is having to eject with each heart rate. So obviously, with each heartbeat, you know that the heartbeat is the heart rate. You know, the stroke volume has to be the amount of blood that's being ejected, right? So preload. That's also the Frank Starling thing. If you were in Harding's class, she uses that analogy with like the picture and everything. But preload, that's the amount of blood filling in the ventricles before the contraction. So, preload, it has the word pre, the um, prefix is pre. So that means before. So how much the amount of blood is in before it contracts? Because again, when it contracts and it's going to go out to the rest of the body, it's going to have that heartbeat, and then boom, you have your cardiac output. But preload, we need to know how much blood is in before. Because if you don't have, let's say if the patient is has a really low blood pressure, they've been bleeding. If you don't have any blood, then how are you going to be getting a proper stroke volume? How much, if you don't have enough, then what can we do? So afterload, pressure the heart has to overcome to pump the blood out to the heart, right? So again, the prefix for this is after. It literally says after. So again, what does now this is talking about pressure because what does the heart have to do to overcome the amount of blood that's being pumped out to the rest of the body? So it has to keep pumping, pumping, pumping. But what is the pressure that the heart has to take? What is that workload to be able to overcome to pump the blood out? So again, let's say if you're having some, so you know that it goes from your left ventricle then to the rest of the body through the aorta and all that stuff. But if you have some vessel damage, or let's say if they're very constricted, now the heart has to even work even harder to get this blood out to the rest of your body because of that fact that maybe your aorta has some damage to it and all of those vessels are super constricted. Um, so now the heart has to even work even more. So that's what we're talking about afterload. It's the pressure the heart has to overcome to pump the blood out. Preload is how much blood do we have to begin with before it contracts. Afterload, what does the heart have to do to overcome any issues externally, or I guess after, like with the vessels, anything like that, to pump the blood to the rest of the body. Contractility is the actual force, right? So force of each contraction. So basically, specifically describes the speed, the extent of myocardial muscle fiber shortening, but really I have to know it's just the force, like of each contraction, right? So that's kind of the definitions there. Again, break it down a little bit more if you have to. But that's really, I feel like she if you don't understand that, that's when it's like I don't think she directly asked, but I think it is kind of it makes things a little bit confusing. So when we're talking about preload and afterload, again, preload being before, afterload meaning after, what does the heart have to do to overcome to pump blood out to the rest of the heart? Factors that affect preload, blood fluid volume overall. So that's what I talked about earlier, right? If you have no blood in you, of course, you're not going to have that much blood being ejected to the rest of the body because you have no blood. You have no fluid volume. So that's why we give RBCs. We give boluses because, again, we need the volume to be able to be for the preload because that's a part of the stroke volume, which is just blood being ejected, um, how much blood is being ejected overall. So if you don't have any fluid volume, of course, you're not going to have anything. Venous return. So again, going into these terms, venous return, what is coming back to the heart? So again, talking about anatomy, you know that the blood is taken away after it comes out of the right ventricle to the pulmonary arteries, comes to then it goes to the lungs, goes back to the pulmonary veins. So and then it goes back to the rest of the heart. And also, we're talking about venous return. We're also just talking about like the superior vena cava, inferior vena cava, that goes to the right atrium, right? So it goes superior inferior vena cava to the right atrium. Again, this is all anatomy talking about blood flow. That is how much of that blood is coming back to the heart for the superior vena cava, inferior vena cava. But technically, too, you could also correlate it to like, oh yeah, remember like the pulmonary veins goes back to the heart. But really, more of what we're talking about is the superior vena cava, inferior vena cava going back to that right atrium. How much blood do we have to begin with? And that's the very start of the blood flow in the heart, right? So if you're having issues understanding that, you need to break down that blood flow. But really, venous return, how much is blood is coming back to the heart. Because it could also be the case where maybe it's not necessarily a fluid volume issue. Maybe it's just that something's happening in your venous system, something's happening with your vessels, and it's not being returned back to the heart. In terms of compliance, that stretchability that we talked about, right? Um, if it's not super stretchy or if it's too stretchy, you can either have too much volume or too little volume, right? In terms of medications that affect venous dilation, it can decrease preload or it can have it to be constriction. So then you can increase preload through that. And that makes a little bit of sense too, because again, if you're having dilation there, basically you're having more, probably you're going to have more blood coming in. If you're having constriction, you can have other issues there. So really, I just kind of think about it though with fluid volume overall. I feel like that's just the best way to think about it. With afterload, it kind of is the same thing, because again, with blood or fluid volume overall, um, I kind of think about it like almost if you're having too much fluid volume. If you're fluid overloaded, the heart has to work even harder to pump the blood out. Because there's so much edema, so much fluid that it's having to like really pump. It's having to really force it out there. Compliance of the vessel, same thing, stretchability of the vessels, kind of what's happening there. Um, Arterial vasoconstriction, flow patterns, infection, and sepsis, because and again, infections and sepsis, you're having vasodilation, so the vessels aren't working as hard, right? And then medications, those can also cause vasoconstriction. But with these, I feel like all she's really wanting to know is if you understand what is preload, what is afterload, and kind of just understand that basic stuff of what I was talking about of like, okay, yeah, it makes sense why this would happen. Okay, age-related changes, you guys know everything's going to be decreased except for your arterial pressure. And that kind of makes sense because then people end up having hypertension as they get older. And then obviously, if it's something that's bad, it's going to be increasing. Left ventricular ha- um, hypertrophy, that's going to be your heart having to work hard, because again, left ventricle pumping that heart out. And that naturally happens with time. So that's going to be increase. Anything bad, increase, you know, obviously anything function wise, decreasing. So you guys know already. But she doesn't really ask, I feel like, a lot of geriatric consideration stuff that I feel like with Harding she did. But anyways, point of the story. So getting to the next part, cardiac index. So we know cardiac output. How much cardiac output is the amount of blood that the blood is ejecting through each heartbeat. The heart rate is the heartbeat, obviously 60 to 100. And then in terms of the stroke volume, that includes how much blood overall, but we have to consider many factors, including um, your contractility. You have to do preload, afterload. So for cardiac index, what we're talking about is basically the same thing. It's the same exact thing, but now we're taking into account their body surface area. So cardiac output times body surface area. So basically, um, you're going to have a different cardiac output, or technically, because somebody who's very small and petite. My mom is 4'11". She's super tiny. Versus somebody who, I'm trying to think of another person in my family, but we're all kind of short. That's kind of a lie. But, some of my cousins, they're, like, almost 6 foot, and I'm like, they're technically like, my mom could have a lower cardiac output, another person could have another, like, shorter people can have different things. So cardiac index is basically taking into account their body surface area, because obviously it's going to be different for somebody who's smaller and somebody who's a little bit taller, a little bit bigger. So yeah, cardiac index, that's what we're seeing there. You do have to know, I don't know if you have to know the value for this one. I would, but really it's just knowing, make sure you know that the cardiac output is 4 to 8. Cardiac output 4 to 8. And I feel like this one's pretty easy to remember because it's basically half of that, but you're starting at 2.5. So yeah, 4 to 8, 2.5 to 4. So basically you're cutting it in half. Um, but yeah, so now moving on. I don't expect this to go on for that much longer, I hope, for the lecture, because I know you guys have to study. But uh, the way that I thought about this is because whenever she was talking about it, I wasn't in ICU rotation. I've never heard about some of this stuff, and I was like I was genuinely so confused. So it's normal to feel like that. But basically, talking about some of the stuff, we're going to break it down just a little bit and kind of just understanding what are the basics. So, what are non-invasive hemodynamic monitoring modalities? Basically, how do we look at hemodynamic parameters without penetrating the skin? So that includes just doing a blood pressure cuff, right? An ultrasound, cardiac, cardiac monitoring, anything like that. Basically, how we're looking at hemodynamics without having to actually pierce into their skin. So now what are we talking about with invasive? So we have different measures of being able to actually be more specific. And the thing with that is some patients generally do need that. If you're at your end of life, or if there is a patient who has a lot of disease processes or conditions, we do want to get a little bit more specific with looking at what is their actual blood pressure, what is their actual venous pressure, their cardiac output. And even though a blood pressure cuff is great, sometimes, in like an ICU setting, you need to be a little bit more invasive, aggressive with these treatments and really making sure you're getting the most accurate data from the patient. So basically, this includes arterial lines and central venous catheters, right? So these are used for monitoring, not for treatment, right? Same thing with the blood pressure cuff. You're not you're just checking, it's more for data, checking what's going on, monitoring, but not actually you're not treat like if I were to do a blood pressure cuff, I'm not treating anything. I have to actually give a medication. So it's the same exact thing. It's just that now we're a little bit more specific and we're getting a little bit more invasive. So when we're talking about arterial monitoring, basically your parameters that you're measuring. So keep in mind when we're doing the blood pressure cuff, I think I talked about this in third. When you're doing the blood pressure cuff, you're talking about arterial pressure. We're looking at the arterial pressure, right? So it's the same exact thing with arterial monitoring. When you're having an arterial line, it's monitoring your blood pressure continuously. It allows for you to actually see a systolic, diastolic, and mean arterial pressure, just like with a blood pressure cuff, but it's more specific, right? And additionally, the one thing is you can also blood sample from it. There's a specific device that we'll talk about that can help you look at that blood sample. And so it helps you enable frequent gas analysis without repeated needle sticks. Because obviously, in an ICU setting, if I'm going to need that every couple of hours, it's going to get really annoying for the patient to have to keep getting a bunch of sticks, and also genuinely, it can be really hard on the family. They have to keep seeing that that their loved one has to keep getting sticks and everything. So again, indications: obviously, critically ill, major surgeries, frequent blood pressure monitoring is needed. Right, there's a lot of different things. So that's what arterial monitoring is. Same thing as a blood pressure cuff, but invasive, more specific. You're continuously looking at that, shows you those things, and it also allows you to get some gas analysis, blood sampling with that. But specifically, again, it's not used as a treatment. It's just for monitoring. Venous monitoring, same exact thing, but now we're talking about central venous pressure. So I guess what is central venous pressure? So arterial, we're looking at the pressure, right? Within your blood pressure, we're looking at that. Central venous pressure is more of talking about like how much, what is your fluid status overall, if that makes sense. So blood pressure versus fluid volume status. Um, I can understand kind of what is kind of the confusion, because isn't blood pressure also telling you that? Well, it's also just telling you kind of what your I would think about it like I'm trying to explain it in a way, hopefully, that I don't confuse you guys, but I would think about it in a way where, like, with your blood pressure, you're talking about it does help you look at your fluid volume. It helps you assess that, and sometimes that is needed. But in terms of venous monitoring, it is specific to your fluid status, and it's telling you um, also, what is your mixed venous oxygen saturation? So basically, what is your balance between your oxygen delivery and consumption? So it's more talking about fluid management issues, right? Requiring medications that need central access or monitoring in critically ill patients. But I would just think about it like with venous, you're more talking about your fluid status. With arterial, you're more talking about the pressure. So try to understand that those two things are different. And then additionally, when we're talking about pressure lines, okay, that's where I think it gets a little bit confusing. We're talking about a pressure line that's basically a catheter inserted into an artery or a vein that connects to a pressure transducer, and we'll talk about that stuff, allowing for continuous measurement. Pressure lines are the tools used in arterial and venous monitoring. They're used for both. So again, we know the venous monitoring more for fluid volume status overall. Arterial monitoring, obviously, you're just looking at the blood pressure, which does help you see again the fluid volume status, but it's not necessarily as specific to the venous pressure, the venous monitoring, which is specifically telling you your fluid status. Um, okay, so let's move on. So a pressure line has a catheter and a transducer. So pressure lines is a catheter inserted into an artery or vein. So we know that, and it connects to a pressure transducer. Um, so a catheter, it's a tube inserted into a blood vessel. It can either be an artery or vein. Obviously, we know that. And then a transducer, a device that converts the pressure measured inside the catheter into an electrical signal, which can be displayed on a monitor. Okay, so we're talking about the different things here in terms of the mechanics. So I feel like sometimes it's like, when you go to IKEA and you have to make new furniture, it's basically you having to understand how this whole thing works and the different systems and parts with that. Also, to kind of go back to the arterial and venous monitoring. So arterial, when we're talking about the blood pressure, we also just want to see is blood being pumped through the vessels? Is it going to the rest of the body? How much of this blood is going out to the rest of the body? Are our vessels doing okay with pumping this? Whereas with the venous stasis, with the venous monitoring, that's more about looking at your fluid volume, right? When I'm getting a bolus, that's going into my venous system, giving me some hydration there. So that's where the difference is within those two as well. So talking about the mechanics, pressure bag. The pressure bag holds a bag of saline. Okay. The pressure keeps a constant flow of saline through the catheter to prevent blood clotting inside the main line. So a pressure bag is basically used, for pressure to keep a constant flow, but it also helps to prevent any of these other issues like clotting from happening. Okay. So obviously the saline, the next part, solution, continuous flush, keep the pressure line open, and it helps to maintain the accuracy of the pressure readings and again preventing the catheter from clotting, the line from clotting. So pressure tubing, same thing as before, right? Same tubing connects the catheter, inserted into the patient. It goes to the transducer, which we'll talk about because that's new. But basically, it connects to it, right? And it transmits the pressure from the patient's artery or vein to the transducer. So it basically acts as like a little vessel between that, right? So it acts as a excuse me, a catheter. Like so, it just goes. It's the same tubing as before, but this time, now that we're monitoring, it also picks up this um, and sends it. So transducer is specifically, I think, the new thing that it's like, okay, what really is it? And there's a picture over here that kind of tells you these different parts. So that transducer in the middle right there is kind of what we're going to be talking about. So it translates the pressure inside of the blood vessel into a waveform. So you know how like the EKG has an electrical signal that does send it to the monitor? It's the same exact thing. It translates the pressure inside the blood vessel into a waveform that then can be displayed on the monitor. So we need to do different things though to get a good reading. Because again, there's a lot of different things and you have to be very particular. And why? Well, you're talking about somebody's venous pressure or sorry, venous monitoring and what's going on there, their status, their fluid status, and you're talking about the arterial pressure. You're wanting to just look at their blood pressure, see what's going on. So again, we need to have stable readings. If my patient's sitting up too high, sitting down too low, you can alter those things. And we're trying to get the most accurate reading, so you have to level it. And we'll talk about that. But really, the transducer, it's what's helping to translate that pressure, the blood vessel, into a waveform to be displayed on the monitor. So you have a stopcock, which is basically a three-way valve that controls the fluids and the pressure readings. It's almost like a switch, right? That lets doctors control if the liquid flows or stops, right? So it's basically a switch, basically is how I would think about it. And so that allows us to zero it. So it's kind of like, before a patient gets into a bed, you have to zero it. So it can be stable, and then when they get into it, then you can weigh them, right? But you have to zero the bed first. I'm trying to go back on my calorie deficit. I have a little scale, right, that measures the grams of what I eat, and you turn it on. If I were to, let's say, have a Tupperware, I don't want that to be counted into my grams of what I'm eating because, again, I want to eat as much as I can in terms of grams. So then it's like, okay, I'll put the Tupperware on there on the scale. I'll zero it on the scale, and then I can add whatever food I have in, and it doesn't take into account obviously the weight of what that Tupperware weighed. So that's why it's the same exact thing here. You need to zero it first so that we're not going a little bit crazy. In terms of cable, that connects the transducer to the monitor, which makes sense. It's literally a cable. It transmits that signal to go there. And then in terms of the waveform, before I move on, that's basically exactly how it is. It's a visual representation of the patient's pressure, whether that's arterial or venous, and that displays excuse me, on the monitor. It shows the pressure changes over time in a graph form, and that's what we're going to talk about in a second with like the waveforms. But just know that like with the transducer, that's the part that's talking about like what it's literally translating the pressure inside of that vessel into a waveform, so you can see it on the monitor. The cable helps to transmit that signal. The stopcock, we just need to remember that we do need to zero that. It helps basically to act as a switch, as a three-way valve to control the flow of fluids. And you kind of will see it when you're in ICU setting if they use it. You can kind of see the changes in the waveform, and they will. And when you're like zeroing it, you'll see that it kind of like changes the patient's um, like status and kind of what they're looking at or what their data is on the screen, their waveforms. So air fluid interface, basically in the context of pressure monitoring, it refers to the point where air meets the fluid in the system, right? So the saline. So in a pressure monitoring system, air bubbles can obviously interfere with the inaccurate transmission of pressure signals from the patient to the transducer. So in this case, the air fluid interface is the boundary between air and the saline solution. Inside the pressure monitoring tubing, ideally the system should be completely filled with fluid because fluid efficiently transmits pressure changes. So it's almost like how in an IV you have to prime it before, because you don't want to have any air in it. You're trying to make sure there's no air. So basically, you want to make sure you're keeping the fluid and the saline, the tubing full. So that's why it's important that we have the pressure bag, that saline right there, because it prevents any blood from entering or clotting, and it provides that consistent flow. So we're looking at that proper data and waveforms that the patient has. So, when we're talking about this stuff, this is what we're talking about: the pressure bag, the transducer. We're talking about if they're going to flush it, and then you can see it on the screen, the monitor, the basically the cable. So the transducer is the what converts the pressure into electrical signal. The cable then sends that to the bedside monitor, and you can assess the waveform and you can zero the art line from there. And then we'll talk about other things in a second. So patient positioning. Again, we talked about this, right? It needs to, if a patient, obviously we know that if a patient is having some issues, we can reposition them. Trendelenburg, some studies say it's not really done anymore, but technically on a test, they can still ask that. Um, so but you can do things like that, interventions, such just to help. And it makes sense why we do Trendelenburg sometimes when a person's blood pressure is low, just because it helps to bring all that blood back to the center of you. And if I'm laying like this, all that goes back to the heart. We're having more help there. But at the same time, some studies say it doesn't really, like it's not as effective. But regardless, it's kind of the same concept. You need to have a consistent head of the bed. It's kind of the same thing when you're talking about like intracranial pressure. Like you wouldn't want the patient to be like laying all the way down. So all of the pressure goes into their like head, right? Like they just got surgery or something like that in their head, or in their brain. You don't want them to be in the Trendelenburg, because then all that blood flow is going to the head. You're having more pressure. Then it can cause a lot of things to happen. So, consistent head of the bed. The head of the bed must be positioned consistently, usually around 30 to 45 degrees, because it changes the patient's body position. And that makes sense. So, basically, keep the patient's torso at a steady angle to avoid inaccurate data. And most of the time, again, you're in a critical illness setting, like the ICU. Most of these patients are going to have other things going on. They're vented most of the time. They're obviously going to be sedated. So, it's not too bad to keep them at a certain angle. For the stopcock, right? You need to level it. You 100% have to know this, and they will ask you this 100 times, to the phlebostatic axis. So whenever she asks you, you will specifically put fourth intercostal space. If you want to put fourth ICS, that's fine. And then mid axillary line. It includes both of those things. So basically, again, when we are having it leveled. We just again are trying to level it to make sure that it's at a specific point so that we can provide the most accurate data. And the reason why we do this is because it's roughly at the level of the right atrium of the heart. And basically, this is considered the point of zero to eliminate any effects of gravity, of pressure readings. And that's why our external environment can affect these readings. So that's why studies, research, evidence based practice tells us this point is exactly where we can level it. So, fourth intercostal space, mid-axillary line, that is what you will put if she asks you. So when we're looking here, leveling the air fluid interface is the first thing. You level it. Ensure the transducer is leveling with the phlebostatic axis. Fourth intercostal space, mid-axillary line, that's what we're talking about. It's the reference point that you were to ask is near the right atrium. Okay, what's the second step? You zero it. So again, we're now leveling it. So it's the same thing like with a bed. You're probably not gonna have it like you're gonna level it to you, right? Um, and then obviously like you're gonna get it ready for like the patient to come in. If it's too low, too high, like obviously like that can affect some stuff. Um, with zeroing, basically you're eliminating any influence of external pressure on this transducer because it has to basically get that pressure from your it's crazy how like the technology works, but it's getting that pressure from your arteries or veins or whatever you're monitoring, and then it's going to transmit into a waveform, but you need to zero it, right? Same thing as like zeroing a bed before a patient gets into it. You need to zero it. Same thing as me weighing my food. You have to zero it. So you zero the stopcock, after that. So how do you do that? I don't know if she necessarily asked this, she just asked, like, for the steps of level 0 square wave, but just know that you turn the stopcock. So you turn the stopcock to an open system, to the air, and it's closed to the patient, and then you zero the monitor, like, on the monitor basically, you turn it, you're gonna turn it, and it's like basically close it off to the patient. You're going to and you'll see it, like, in an ICU setting if some nurses do it. I've only seen it, like, once or twice, so even I'm still like, "Ugh." But, when you're looking at the monitor, you're going to then zero the monitor, it literally will say 0, you're gonna say 0, and then after, basically what it does is this is telling the machine to reset the like, the pressure in the atmosphere from the readings, so you're zeroing it, and then now you're gonna close the stopcock now, you're gonna turn the cock back close to the air, and open it to the patient. So now the system is like really ready to read. So really, you turn it off to the patient. You set the monitor to 0, and then you're gonna close it, turn it off. So that's basically you zeroing. I don't know if you have to know those specific steps, but I do know you have to know level 0, level fourth intercostal space, mid axillary line 0. That's basically to eliminate anything, and then square wave test. So this is basically how quickly an oscillating system comes to rest. So basically what we're talking about, oscillation basically means like small waves, right? So then you'll see the waveforms. So how do you know that it's working? Well, the way that you know it's working, and you can even see it when they're doing it. So the test that they do is by quickly pulling like the flush valve. And really what that does is that, okay, so you know that there is saline running through the tubing system, right? So if I were to press this flush valve, it produces all of that like uh saline to it's like you're almost flushing like um saline flush almost. So you're just pulling this little thing, this flush valve. It allows it to go, and then you'll see on the waveform because obviously you want to make sure everything's gonna like the transducers reflecting the pressure from the line to the monitor, right? So, and it's changing that into a waveform. So you want to make sure that's happening and it's monitoring the pressure correctly. So how do you do that? Well, you pull on the flush valve, right? And then obviously it monitors more pressure. You're going to see it on the monitor that there's a more pressure waveform or there's a higher waveform or whatever. So you're going to pull on the flush valve. Now you have a lot like you're basically not a lot, but it's basically like a test, right? Where oops, we're really quickly like giving a saline flush almost, and then on the waveform on the monitor, you'll see it on there where it changes that, and it should create a square wave. So that's basically what we're talking about with the square wave test. So oscillation meaning with the small waves, but we have to make sure it's accurate, right? That there's having a higher amount of pressure right now. So if I pull the flush valve, I know that's basically like giving a fast like IV push almost. I should see on the monitor a change. If I notice that there's no change and I'm like, "Okay, something's wrong with my transducer, something wrong is going on here." Right? Like I zeroed it, I leveled it, I did everything that I had to do, or I leveled and zeroed. Now I'm trying to do this. So if you notice those issues, you notice that something is going on with the system not calibrating and responding to the patient's true pressure changes. So basically, yeah, the test is performed. I'm just going to read it by quickly pulling and releasing the flush valve to introduce a fast, high pressure flush of saline into the system. This creates a square wave on the monitor's pressure waveform, and then the system's response is to basically have a quick pressure change, and it's going to then return back to normal. So square wave test, that's what you'll see there. So Level 0 square wave, what are we leveling it to? The fourth intercostal space, mid-axillary line. Why? Because it's right next to the right atrium. We want it leveled and fine there. In terms of the interpretation, the waveform, the optimal response is the waveform should be a clear square wave followed by 2 or 3 oscillations, and you'll see that. So basically, small waves. Remember, like you're flushing, so you want to see a waveform which changes the pressure before you're returning it to baseline. So that means that the system is accurate. Overdamped, there's 2 or no oscillations. So basically, this could mean that you have air bubbles, clots in the lines. So that could lead to low pressure readings. So that's why we have the pressure bag. We have the saline, so it's continuously providing that constant pressure. So we know that it's accurate. For underdamped, now you're having too many oscillations, too many little waves. And that indicates maybe something in the system is too sensitive, and now you're having too high of pressure readings. So again, interventions for an arterial line, hemodynamic instability. You're trying to look at them for like vasoactive meds, BP monitoring because we want to make sure the blood pressure is going there and that they are being properly perfused, oxygenated, and everything there. So you're looking at their circulation, neurovascular Q2, assessing the waveform, the cuff, hold correlation. So in terms of what their blood pressure is, sometimes you still have the cuff on them and you have them on an arterial line. You hold to prevent bleeding for 5 minutes if you're just continuing a line. No meds. If you have an arterial line, that is a great question. That's why it's not a treatment. You're not pushing anything through, but you can get samples, but just know that you can't be pushing anything into that actual arterial line. Okay, moving on, waveform, really, I'm not gonna read all of this, I'm only gonna talk about the dicrotic notch because the rest of this stuff, it's basically just you're gonna have to read it, she doesn't really ask about it, but it's just kinda talking about how the waveform looks, the electrical precedes the mechanical, you have those different phases there, that kind of match up to the patient's, like, systolic versus diastolic, pressure, but really the one important part that she wants you to know is the dicrotic notch, which basically correlates to it's a small downward deflection seen after a systolic peak, but really it's telling you on the arterial waveform the closure of the aortic valve. So that's right after like the R wave on your like EKG. So I would look at it, take a second to read that, but just know that the dicrotic notch is what we're talking about. So closure of the aortic valve shortly after the R wave. So that's where you see like right at the top it has that EKG, that's the chemical. Now you're gonna have this mechanical response. So it correlates to that right there. And then if you're talking about like runoff, it kind of makes sense because it's like, okay, it declines as the arterial pressure decreases during diastole, which is basically the relaxation of the heart. So of course you're going to have less pressure because now your heart is like relaxing, right? But the dicrotic notch is telling you, okay, this is where the R wave is at. So that's what's going on there. For VAMP, basically, so what I was talking about, it's basically the allows for continuous monitoring of arterial blood pressure, and it actually has an easier access for blood sampling without disrupting the arterial line in case you don't want to keep poking your patient. That's not fun, not cool. So I kind of said VAMP. It's kind of like sounds like a vampire. So blood sampling is what you're able to get from that as well, and it can be added to an arterial line. So a venous arterial monitoring platform, you can add that for those things as well. So central venous pressure, it's basically CVP, right atrial pressure, 2 to 6. I memorized it. I don't know if she ever actually asked about it. So keep that in mind if you have to know these values. But um, basically, what we're talking about, even one quick second. Okay. Basically, what we're talking about for CVP, right atrial pressure. So again, this is knowing kind of the anatomy, right? So but you're measuring the right heart filling pressure, estimating the fluid status. Almost again, we're talking about anatomy wise. What are we talking about? The right atrium. Oh wait, central. It goes from your superior vena cava to your inferior vena cava, and then it goes to your right atrium. So it's like, okay, wait a second. So this kind of sounds a lot like venous return. Yeah, it's basically kind of what it is. Because basically it's how much your heart, but it's more specific. It's having how much of your heart filling. What is the pressure within that? And it helps you to estimate the fluid status because again, we're talking about venous, right? What I would think about is your volume resuscitation, assessing your SCVO2. And so that's similar to SpO2 and SaO2, but this tells us how much oxygen saturation, hemoglobin, right? is measured in a central vein. So it's the same exact thing, but now it's in a central vein, right? So when we're talking about right arterial pressure, I would think about it kind of like, yeah, like how I was saying with the heart. Um, and how that heart is filling. And then again, you can administer large volume fluid resuscitation or vesicant irritants. It has a sheath, which basically has a protective cover or a thin tube that surrounds the central vein, an introducer, which is basically a large bore catheter used to facilitate the insertion of other catheters there. So it's primarily used to create access for placing other catheters. I'm straight up just reading this because, again, I don't necessarily think you have to know this. I think it's more of just understanding it measures right heart filling pressure and estimating your fluid status right there. Um, so I would read it, but at the same time, I think if you just know that, you're honestly set. Like you're fine. So measures central venous blood volume, again, fluid status, talking about the right arterial pressure. So for pulmonary artery catheters, that is another one that we have. So that also helps to treat and identify hemodynamic instability. Really, the big thing with this is that we're looking at your pulmonary arteries, right? So basically, assessing the function of the heart in correspondence to the lungs by the pulmonary arteries, which again, we know that the blood carries it. The pulmonary artery carries the blood away, right? Because it's artery, from the right side of the heart, then to the lungs, then it goes back to pulmonary veins, right? So pulmonary artery, meaning we're just wanting to see what's kind of happening with the function there, making sure that everything's good. And then also can also check SVO2, which is basically oxygenated hemoglobin blood in the pulmonary artery. And that also can directly measure their cardiac output as well. But I would just keep in mind, like with something like a pulmonary artery catheter, like all of these things that we're talking about, you just have to think about like the anatomy of it. You just have to think about again, what is the function of like a regular blood pressure cuff. Now you have an art line, more specific, central venous, right? Where we're wanting to look at their actual fluid status and see what's going on with their fluid volume. So pulmonary artery catheter is another thing that we can look at in terms of looking at what's going on between the function between the heart and the lungs and making sure that we're having that proper oxygenation there. With the SVO2 and seeing the cardiac output. Okay. And then you could just read a little bit. So now going into hemodynamic data. So central venous pressure and right arterial pressure are the same exact thing. There's no difference there. So the reason why I didn't want to talk about CVP kind of here is because we're literally going to be talking about it in a second. So basically, it reflects the filling pressure in the right atrium. And so that reflects the amount of blood returning to the heart, so which is the venous return. So that's why venous return basically is CVP or RAP. And so it just is talking about, the ability to pump blood into the arterial system. Um, so CVP, pressure, central venous system, basically how much blood we got filling, what is the pressure of that. Um, in that right atrium. So don't overcomplicate it. So right arterial pressure, CVP, same thing. So central venous pressure, we're just looking at what's the fluid status overall, what is the pressure that's going on, right arterial pressure, what's that amount of blood returning to the heart, and the ability to pump it out after, right? So the range for this is 2 to 8. So if it's, I don't think you have to know the low and high, but basically what I would say is that with RAP, it's essentially equivalent to CVP, and it reflects the right ventricular preload. So that's basically saying when we're talking about RAP, we're talking more about the arterial pressure. It reflects the right ventricular preload, volume of the blood in the right ventricular at the end of diastole. So RAP, yeah, the same thing. I was kind of getting a little bit confused about my verbiage right now, but I don't overcomplicate it because I know that these things can get confusing. RAP is equivalent to CVP. So don't overthink it. Basically, talking about venous return, what's happening, and then the ability to pump it out after is what we're talking about here. So if it's low, could mean hypovolemia, which makes sense, right? Because you don't have enough fluid volume overall that's coming back. So you don't have anything coming back. You're not having anything to be pushed out. And then in terms of high, that's going to be fluid overload, obviously, because you're going to have to use more pressure to pump it out. So it's the same exact thing as before. CVP, don't overcomplicate that one. Okay. Cardiac output, we already talked about that. How much of the amount of blood the heart is pumping in 1 minute by the heart rate, the stroke volume is 48. So you obviously know that if it's low, that could mean that there's some type of maybe a hypovolemia problem with the preload, heart failure. Maybe there's something wrong going on with the contractility, hyperdynamic states like sepsis with it being high. You have a high demand of the heart because your heart rate is so high. You're trying to pump blood out because your body's wanting to get more perfusion, more oxygenation, everything there. Um, and then also because of the metabolic demands, right? So, in terms of talking about cardiac index, CI, same thing we talked about earlier, just CO divided by body surface area. So basically cardiac output, but now we're taking into account what is the patient's body surface area. So a person who is smaller may not have the same output as somebody who's going to have, because they have less blood volume overall, right? Whereas a whole bigger person is going to have a little bit more blood volume because they're literally bigger. So keeps that into mind. Um, yeah, so now talking about systemic vascular resistance. SVR is the resistance of the left ventricle, what it has to do to overcome to pump blood through the systemic circulation. So now I understand why it gets a little bit confusing because they're the same terms, right? But earlier we were talking about right arterial pressure, CVP. And so basically when we're talking about this stuff, we're talking about specific places. So when we're going here talking about SVR, this is systemic, talking about the left ventricle, what that must do to overcome. So we're talking about over here, the right side, whereas with the RAP, central venous pressure, whereas right here, we're talking about the left ventricle due to overcome. So we're talking about SVR as a whole, right? We're talking about what does the resistance of the left ventricle have to do to overcome to pump that blood out to the rest of the body. So it sounds a lot like when we're talking about afterload, and that literally is kind of what it is. SVR is afterload for the most part. It's basically the resistance the left ventricle has to do to overcome to pump blood out to the rest of the body. That is literally afterload. So that is what afterload is. So that's why it can get a little bit confusing. So again, right arterial pressure, including SVP. We're talking about the inferior vena cava, the venous return going back there, and then what does it have to do to pump it out after that? And then when we're talking about SVR, we're talking about basically the left ventricle, which is again anatomy wise, that's where it's going to go to the aortic valve, to the aorta, to the rest of the body. What does it have to do? The left ventricle have to do to pump that blood out to the rest of the systemic circulation. But if you think about the name, systemic vascular resistance. So systemic, we have to get it out to the rest of the body, to those other vessels. And what is the resistance to that? Well, what is the place that in our blood flow sequence for the atriums, ventricles, whatever, which one is the one that's having to pump the blood out to the rest of the systemic circulation and vessels? Well, that's the left ventricle. So it is the same exact thing as afterload, um, and that's how you should think about it. So it tells us the tone, constriction of the vessels. So again, those same factors. If you're having vasodilation, vasoconstriction, it's going to be the same thing. So again, looking back to right arterial pressure, central venous pressure, basically how much is it filling up inferior vena cava to the um, right atrium, and then the venous return that's happening there, and then what is it going to do to pump that blood out to the rest of the body after that. Okay. Pulmonary vascular resistance. So now so all we're doing here is we're adding the word pulmonary to that. So it's getting more specific in terms of pulmonary. So pulmonary vascular, pulmonary vessel, right? So PVR is the resistance of the right ventricle to must overcome to pump blood through the pulmonary circulation. So again, guys, this comes down to understanding the anatomy. So after the right ventricle, what does it go to? Right? Well, you know that again, right atrium, right ventricle, then it goes to the pulmonary arteries, then it goes to the lungs, and then it comes back via the pulmonary veins, right? So now when you're looking at pulmonary vascular resistance, it's the same exact thing as SVR, but the only thing is we're talking about it's wanting to go to the lungs instead of the systemic, right? So systemic starts with an S, pulmonary starts with a P. So of course, SVR. Again, working about anatomy wise, what part of the heart is going to be sending it to the rest of the systemic circulation? That is your left ventricle because it goes to your left ventricle, then to the aortic valve, to the aorta, to the rest of the body. Pulmonary vascular surface, vascular resistance. Pulmonary vascular resistance. Okay, pulmonary, it's the same exact thing, vascular resistance. What part of the heart is going to have to work hard to pump blood to go to the lungs? Well, that's going to be your right ventricle because it goes from your right ventricle to your pulmonic valve to the pulmonary arteries to the um, to the lungs. So that's why those are the differences there. So this one's talking about the right ventricle. But again, if you just know your anatomy, then you know it's going to be the right ventricle for this one. The other one's going to be your left ventricle because they're again anatomy wise, they're going to different places. So yeah, PVR is the resistance of the right ventricle having to overcome to pump blood out to the pulmonary circulation. And it also tells us what's going on with the constriction and tone of your pulmonary vessels, right? Because it's too constricted, not too dilated, you can have differences there within that resistance, right? Because we talked about at the very beginning, with the viscosity, with the thickness, the length, all of that stuff. Okay, so now talking about pulmonary artery systolic pressure. PAS, that's basically measures the pressure in the pulmonary artery during systole. So the heart's contraction phase. So this one, now you're going specific into, because this one's talking about what is the actual pressure within the pulmonary artery. The ones before, they're still talking about what the heart has to do to technically overcome to go to these things. And they can still tell us what's happening with their vessels. Because if the SVR, PVR, if they're either too high or low, that's telling us, well, something's going on with these vessels that they have to, that the heart has to overcome, this ventricle or this, um, the ventricles have to do to overcome because something's going on with the vessels. It's either too constricted, too um, dilated. So that's why keep in mind too when you're talking about like resistance, we're talking about what does it do to have to overcome this. We have the word vascular in that, so vessel. So pulmonary artery systolic pressure. Now we're talking about the specific pressure within that, right? So pressure in the pulmonary artery during systole. It's almost like that's what the name is, right? So don't overthink that. Pulmonary artery systole pressure. So systolic pressure. So basically heart's contraction phase, because you know that systole is the heart contracting in that phase. Again, there's the range for that. She never asked us about that, but also that's just another thing to keep in mind. And then when you're talking about pulmonary artery diastolic pressure, same exact thing. But now we're talking about diastole, which is the heart's relaxation phase. So those are the differences there. So it's not too confusing. And then for PCWP, pulmonary capillary wedge pressure, or it's called POP. This is an indirect measure of the left arterial pressure, and basically it reflects left ventricular preload. So basically, pressure in the left atrium, and is measured by inflating a balloon-tipped catheter within a pulmonary artery branch. So I guess like, okay, what's the difference now between the left arterial pressure and the right arterial pressure, right? But remember, right arterial pressure was talking about what? That was talking about the right side, the right atrium, right? This one's talking about the left atrial pressure. So those are the differences there. So basically, don't overcomplicate that. Again, that's just knowing the anatomy of that, the left atrium. So it's going back to the lungs, or it's going from the lungs. Now it's coming back by the pulmonary veins. And then what's going on with the left arterial pressure there? And how much pressure is in that left atrium coming off of the fact that we just had that blood go to the lungs. Now it's coming back to pulmonary veins. Now it's going to be oxygenated. Now it's coming into the left atrium. But if there's no pressure there, if I don't feel any blood coming back to me, then we know there's an issue going on there. So that's where the differences are. It's just that PCWP, all you have to know with that one is it's basically, I don't know why they decided to call it PCWP. But I would just, if you think about the name, it makes sense. Pulmonary capillary wedge pressure, how much it's going back. But really, it could just be LAP. It's just left arterial pressure is what we're talking about. And then, yeah, you obviously see that by doing the balloon tipped catheter through a PAC or with a PAC. And then, yeah, so left ventricular preload is basically what we're talking about. Pressure in the left atrium, and then it goes to the left ventricle. And then that's where we get like the systemic vascular resistance because that's more talking about the left ventricle. So do you see how every single part of the heart has their own measuring system almost in terms of knowing what is going on with the heart and the lungs and the vessels? How do we see what's going on and how do we have that correspondence? We can look at the heart having to overwork to look at the vessels, to look at the fluid status, look at their blood pressure, all of these different things. So we have all these things set for a reason, but each one kind of has its own, like the right atrium, central venous pressure, right? Because it goes from superior inferior vena cava to your right atrium. That's what we're looking at, the venous pressure. And then what does it have to do to pump that blood out to the next thing? Cardiac output, that's a different thing. Cardiac index, that's your overall stuff, right? So taking all of this into account, cardiac output takes all of that into account, but really is just talking about what's the total amount of blood, right? And these are the little factors within some of this stuff. And then After that, like, what is the cardiac index? Let's just take into account body surface area. But now it's like going down. It's like, okay, you have in the right ventricle, that's PVR, because now you're talking about like, okay, it's going to go to the lungs, pulmonary, it's going to have to be the blood is going to have to be sent to the lungs by the right ventricle, so that's PVR, right? Because again, pulmonary vascular resistance, what does the right ventricle have to do to overcome that? And then after you're looking at the pulmonary artery systolic pressures, the diastolic pressures. Now you're talking about the actual pressures within the arteries of the pulmonary artery. And then when you go back, it's like, okay, now it's going to go back to the left atrium by the pulmonary veins, right? So then it's like, okay, pulmonary capillary wedge pressure. That's basically talking about left arterial pressure. So it's up there. And then, okay, SVR. Well, now it's now after the right left atrium, it goes to your left ventricle. Okay, what do we have to do in terms of what's the blood circulation or systemic circulation, excuse me, look like, and then how do we pump that out to the rest of the body? How is the left ventricle going to do that? What does that look like? What if the systemic circulation is too constricted, too dilated? Things like sepsis, hypertension, anything like that. That's another thing. But do you see how like they're each kind of having its own thing, and then you also just have the weird ones like PAS, PAD, but that's just talking about diastolic and systolic pressure, cardiac output, cardiac index, just talking about the overall stuff. So each one of them have its own set, and the reason why again is because we're trying to look at the systemic circulation, the pulmonary circulation, and trying to make sure that each part of the heart is having an adequate amount of pressure or resistance, having an adequate in range data. Because again, you don't want your heart to feel like it's having to overwork, because that is our most technically important organ. Um, Absolutely. So that's kind of how it works out with that. The names are is what's hard to kind of understand, but if you understand that CVP, RAP, basically the same thing. Um, and then I feel like the rest of the ones, it makes sense in terms of what we're talking about with um, like the anatomy. Like obviously pulmonary vascular. Oh, well, that's your right ventricle goes to this. So then uh, PCWP is the other one that's kind of weird. It's just like out of nowhere, kind of I can understand how the name's not as straightforward in terms of the anatomy, but again, that's just talking about left arterial pressure. Why they decided to call it that, that's their own thing, but basically LAP. So essentially, to kind of end this thing, arterial line focuses on continuous blood pressure monitoring and arterial blood sampling. Central venous catheters provide information about the venous system, including venous pressure and assessing for medications and fluids. And then pulmonary artery catheters, they give specific insights into cardiac and pulmonary functions and by measuring the stuff in pressures in the heart and in the lungs. And that's where you see all of these hemodynamic data coming from that. And then obviously the other thing that you do have to know was what's the number one, I forgot to write this down, but what's the number one organ system affected by low cardiac output? That's going to be your renal system. Okay. That's going to be your kidneys. A lot of people want to think it's your respiratory, but if you think about it, low cardiac output, that also changes a lot of stuff within the RAS system and all of those things there. But other than that, I'm gonna let you guys go. Have be studying. Hopefully this is able to help. Don't overthink this. She didn't ask us a lot about this information. As long as you, I think, listen to this part, you'll be fine. But really, it's just understanding more of okay, dicrotic notch. You don't give things to arterial lines. You don't do that. Don't. It's not a treatment. It's just monitoring. You level. You zero. You square wave. What's the position for the level, fourth intercostal space, mid axillary line? What is a transducer, kind of some of that stuff. And then, yeah, what is the normal cardiac index, cardiac output? What is afterload, preload, cardiac output in terms of what's that equation? But if you know those things, those are really the things that she's going to focus on. I don't think that it's kind of like with the vents. I don't think that she necessarily like went into detail about the vents at all. And then same thing with these values. She like I studied them and I remember she didn't really talk about it, and I was like, oh, but yeah, if you listen to that, I think you should be fine. Read it through, study it maybe a little bit, but that's not going to be your focus, and that's not what I would recommend. But again, it is kind of fair game for everything, so just keep that in mind. But other than that, have a good rest of your day, guys, and we'll do an exam review hopefully tomorrow.